Hey everyone, welcome to the FunkBed Nation podcast. I'm your host, Dr. Steve Noseworthy. The views and opinions expressed by my guests in this podcast are not necessarily consistent with my own views and opinions. However, I do my best to be respectful of their views and opinions as they express them, even if they differ from my own. Now let's get to the podcast. I think you've done a great job of laying the groundwork of understanding, at least fundamentally, how the brain and the immune system interact with each other. And I think most people in functional medicine these days understand that changes in the immune system affect brain function. We're looking at that relationship from the other direction. And you're expanding this into now there's a memory capacity here and there's a modulating capacity. So on the clinical side, there's a couple of things that pop out to me that are so very common in clinical experience. We just kind of mentioned that more complicated case. I don't know if the terminology has changed, but in functional neurology, for many years, I've referred to many of these cases as what we call, mesolimbic plasticity. Mm-hmm. So what I would like to do is have you talk about mesolimbic plasticity, maybe the kind of the mechanisms behind it, how it presents clinically, and then maybe start talking about how we can put the brakes on the mesolimbic system and how does all of this relate back up to the insular cortex? Because to me, that is probably the most obvious expression of when the how do I want to say it? When the neuroimmune system goes wrong, that is what I think it looks like, at least in the people that I work with.
Sure.
Right. So let's have that conversation about the mesolimbic system and plasticity, and then maybe merge into talking about parts of the brain that help to control that. And, I think part of the conversation should be the role of the vagal system and then harnessing that from a therapeutic standpoint. And I think what I would love to leave people with is not just the mind-blowing aspect of, hey, guess what? There's stuff that we don't understand and you need to know it, but a little bit from the application side, okay, I know it, what can I do about it? Sure. Knowing that we're not going to solve that whole puzzle just in one conversation. So Let's start with the mesolimbic system and what is that and what is mesolimbic plasticity?
Sure. Well, I don't think you can define mesolimbic without talking about the pathways that construct that in terms of, when we went to school, we looked at pain, and the primary pathway coming from the spine to the brain was the spinal thalamic tract. Okay. And looking at how your pain fibers came into the spinal cord and then they summated on the thalamus. Okay. But you read current textbooks, they don't define it as the spinal thalamic tract anymore. They define it as the anterior lateral system. Okay. And that consists of not only the spinal thalamic tract, but the mesolimbic tract and the reticular tract, the spinal reticular tract and the spinal mesencephalic tract. Okay, so and what that does is allow us to go. Okay, when we pinch our skin, we get a sharp, let's say, attack. We perceive the sharpness of it, but then the mesolimbic side of it and the reticular side of it's going to give us the idea of the feeling of the pain, okay? Not just the description of the pain. And so in that pathway of mesolimbic aspect, you're talking about the mesencephalon, the midbrain, and the area of that where we're going to allow us to, really pick up on pain modulation. And then we get into the reticular tract that allows us to feel exactly the type of pain that we're having. And so what we know about those areas is that the cells in those areas of the mesencephalon are very sensitive to cytokine shifts and on the receptors of those cells. And in very particular...
And you're saying cells in the mesencephalon.
In the mesencephalon, yes. Yep. Okay. And very specifically, the interleukin-6 aspect, okay? And we know that interleukin-6 is a pro-inflammatory. We also know that there's some aspects of it might be a little bit of an anti-inflammatory, that it oscillates, but in a lot of instances when we create higher levels of IL-6 production, we're going to create more of an inflammatory response. And that particular response then seems to increase receptor saturation to those areas of the mesencephalon. And in that area of our brain are connections to our limbic centers of our brain, our emotional centers of our brain, but also our arousal centers of our brain. Right. And then what we also know is that we have our frontal cortex, and both frontal cortex is on the right and left. We know that there's primary pathways that come down that we refer to as our frontal striatal networks, okay, that are trying to always keep a modulation on these more limbic pathways, or, you know, our older structures of our brain, okay? And we also know that inflammation can have a real big effect, especially neurogenic inflammation in the frontal cortex, and that all of a sudden now we can inhibit those mesolimbic pathways. So now those pathways are coming to a higher level of excitation. So in an inflammatory state, we get the onslaught of activation to the mesencephalon regions, but we also can dampen the frequency of firing of our frontal lobe, and now we lose inhibition. And so at the thalamus level that we've talked about briefly, is that the thalamus is just cranking away. It's getting bombarded with a lot of this sensory input that when our brain is healthy and not inflamed, we modulate that input.
Right.
And so now we get these patients that are really wound up, and then does that lead to, in the neurology world, what we would term as perseverations? Do they get these thought patterns now that become more fixed? Okay, I think that's a big thing in the chronic pain world, is that you know, patients that are constantly thinking about things that they're worried about, whether it's their leg pain or some other thing, or they're worried about a certain food that is going to trigger an immune response. And so now they're just hyper focused on that. And so, so we're just getting this multiple loops that are happening simultaneously from the inflammatory response.
Let's try to connect that back, because I think you said something very important there, is that, you know, with perseveration, like we know a lot of chronically ill people, like this is so important that I actually have a question on my intake form. Are you a glass half full or a glass half empty person?
Yeah.
Right. And if somebody says, like, I tend to fall on the negative, I'm kind of a glass half empty. And in my initial consult, I might ask them questions about, you know, do you spend a lot of time thinking about negative things, whether that's about, you know, worried about your health or problems in your marriage or problems at work? Because the more somebody spends time ruminating, and this is, I'm trying to connect the dots here, that if we now have an understanding that immune and inflammatory events in the peripheral body create an imprint of memory in the brain, that if we activate that part of the brain, we can activate the immune response in the body in the absence of some type of peripheral trigger. That person who has this plasticity in their mesolimbic system can have emotional responses to memories of perhaps unpleasant things and create systemic inflammation and more local inflammation in parts of the body that's been injured in the past. Is that a rational connection to make?
Absolutely. Yeah. And I can take it one step further by saying that within that inner area that we're talking about, which the mesencephalon, we're talking about the upper region of the brainstem. Okay, we also know it's intimately related to an area of the brain called the basal ganglia. Okay, and you know, the traditional thought of the basal ganglia when we went through neurodip class was the fact that we had two primary pathways that were in the basal ganglia: the direct pathway that allows for excitation to the cortex, and then the indirect pathway that is providing some level of modulation. Okay. Right. Well, we also now know through a lot of network studies that the left hemisphere has a greater influence on the activation of the direct pathway, where the right hemisphere has a greater influence on the indirect pathway. And then let's say about 15, 20 years ago, they uncovered a very specific pathway that's only coming from the right side of the brain called the hyperdirect pathway. And the hyperdirect pathway is coming from the inferior frontal lobe, and it's also coming from the supplementary motor cortex. Mm-hmm. Now, it's coming only from the right side, but it's going to act on both basal ganglia, okay? Now, in our world, the world that, in the developmental neuroscience world that Dr. Melillo and I will look at, one of the things that we're always seeing is that we're seeing patients that have a greater activation of that direct pathway, okay? And when you get a greater activation of the direct pathway, not only are you going to get increased motor firing of the brain that may come out in the form of any type of hyperactivity or impulsivity or a tic or Tourette's. But then you can actually have the cognitive piece of it, okay, that's now lighting up all the cognitive networks. And there comes what you're talking about, that illumination, the perseverations, okay? So, and what we're also looking at, and then again, in the earlier work of the T-cell polarization was the idea that, does the left brain tell the immune system to go? Does it turn on the Th17 immune response? Does it promote more of maybe even the Th2 immune response as well? Okay. Or just generally the immune response in the general context. Okay.
Right.
And so now all of a sudden that you get this person that might be pushing that left brain activation because their own thought pattern. But then what if they're getting online and now they're part of this, whatever Facebook group they are for their syndrome or whatever, and they're just getting reinforcement of that. Okay. Yep. Could they literally just be stimulating the heck out of their left hemisphere that's continuing to drive a pro-inflammatory response? Yep. And then the right brain through the hyperdirect pathway is not strong enough to maybe dampen that response. And at the same time, we also know the right brain has probably a greater presentation of vagal influence. So now the inflammatory reflex loop can't come down and modulate that peripheral inflammatory response. Yeah. So now we're just in that state where we're pumping out IL-6, we're pumping out NF-kappa B, driving a STAT3 presentation, that whole loop there, TNF alpha. And you're just reinforcing these loops. Yeah.
So, and just for clarity, like it's not like, I'm asking this very sarcastically, but it's not like there's a specific herb you can take for your right hemisphere to drive the hyperdirect pathway.
No.
Or something to specifically, like, some vitamin, mineral, or supplement inhibits the left indirect pathway or something like that, right? Or is
no, I mean, the work we're using now is we're using transcranial stimulation to do that, okay? That can allow us, especially transcranial stimulation with direct current stimulation, where we can do an excitatory activation and an inhibitory activation. So if we feel that the right hyperdirect pathway needs to be activated, we can do an excitatory activation to that. And then we can also place the electrodes in areas to dampen down the direct activation. The work that's being done in photobiomodulation, low-level lasers, that work is just unbelievable right now, that we're beginning to understand the capabilities of not only with the frequencies that we're using for pain modulation and inflammation, but now beginning to understand the wavelengths that we need to use to increase some of these neural networks. Like we know, for example, when we do QEEG work, okay, this has been well defined by Dr. Melillo, but other researchers, that those patients that might be more in that illuminated mode or perseverative mode, or let's say they're classically diagnosed with anxiety or OCD, they typically have high beta brainwaves. And so their brain waves are firing at a faster level. So we should have beta brain rhythms, but they seem to have an excessive amount of brain, and especially in that left side of their brain. Okay. So now with photobiomodulation, we're being able to see ways that we introduce slower brain rhythms, like a delta theta brain rhythm, to kind of calm down that high beta rhythm. And that's what we're seeing now with our work with being able to use these modalities and then reimage or do the QEEG or just see symptomatic change in the patient.
Yeah. And you're selectively affecting different parts of the brain by choosing different wavelengths of light.
Yes.
Or different frequencies if you're doing transcranial direct current. Is that what you're using?
Correct. Yeah. And then even in the work that I know others that are colleagues of ours that are doing it in the transmagnetic realm as well too. Okay. And I think there's going to be a huge place for that as well. Okay. So we're getting back to more specificity. The idea that can we inhibit or excite certain neural networks. Okay. So for example, like with low level laser, we might be doing things at a low level laser level to change the patterning of the brain rhythms with the low level laser when we're shooting at the brain. But then in the peripheral, we might be at a different frequency at a localized tissue to calm down the inflammatory storm that's going up the afferent pathways to the brain. At the same time, you also probably doing your functional medicine work as well.
Yeah, and I think they have to be done in parallel for sure. So, in fact, I want to come back to the clinical stuff, but just to reiterate on the mesolimbic stuff and where, like, how. Let me ask you a question and have you answer it rather than me posing something. If someone comes into your practice and there is a problem with immunoception, how would you, like, what does the prototypical case look like? What are the complaints? What are the presentations? What are the promoting or aggravating factors? Just so that we can give people listening something to latch onto, that if they hear this in clinical practice, they might go, okay, this is brain immune dysmodulation.
Yeah, well, I mean, for me, I've seen it in just people with generalized headaches. I've seen it with people that obviously have, various systemic, pain that's happening all the time, or chronic pain syndrome, patients that have had, this going on for many years, even just the generalized GI aspects. I think that all that can probably be put under the term of immunodysfunction. And then from there, you're saying now the question is like, how am I localizing it and trying to determine, and so to me, you're going and you're doing your laboratory workups and you're looking at your inflammatory markers, but then are you taking it one step further and saying, okay, can I begin to look at this T cell presentation or the T cell polarization presentation based on some classical markers, but obviously some advanced, immunological markers and labs that are out there that give us that. But yeah, I think for me, then also paying attention to, again, are these patients that, for example, you look at somebody that if they have, let's say, a low right brain hemispheric, they may not be as bodily aware of their issues as either. Okay. They may not have this true sense of self. Okay. So we see that in the autism world, but you can see it in the adult world. You can see, patients that, if it's an adult patient and they walk in with, let's say, hey, I may have an adult ADHD, or, some of the adults that I've worked with over the years, definitely already have, a diagnosis of, like, say, Asperger's or something like that, or maybe have an OCD disorder. You may clearly get a sense that they don't have a sense of self, that they don't perceive their reality very well. And so again, I think that, keys you on to, like, even some of the symptoms they're telling you, like, may not match up to, like, it's a very bizarre clinical presentation, right? What they're telling you doesn't make sense. There doesn't seem to be like a anatomical relation to it, right? That you're going, okay, these symptoms are not jiving with each other. So to me, I think that's a patient that I would look at and go, okay, is that a low right brain type of problem? And are they having really difficulty with interoception? And now knowing that the right insular cortex has so much to do with immunoception, Yeah,
Yeah.
so that's what I'm looking at there is like, do they have a pattern of where maybe some of their symptoms are not matching up?
Right.
You know, in
So does that, do you think, can that manifest in just in doing your initial history? Because I've had many clients over the years where I'm asking them questions about, if this, then that, or how does this show up? And the answer is, I don't know. And it's usually, I've never paid attention to it.
Mhm.
And, it seems to me like every time I've had a problem, like I know I have a problem and
Yeah.
I usually know what flares it and what helps it. But there's a lot of people out there that just don't seem to have that awareness. Now, is it a problem of they're not paying attention, or do you think it's a problem of interoception and that right hemisphere and that insular cortex maybe is not as robust as it could be?
Yeah, I think it's definitely that. I think it's probably more the idea that, especially when you even go to examine them and you start doing like some tactile examinations or you do some parietal lobe testing and they don't connect to their body. Okay. And so, yeah, I think to me that from what I've seen is that you see a lot of patients that seem to be disconnected from their body. They don't have that
Yeah.
perception. Because I know for me, like, I'm a pretty right brain dominant person. And so, yeah, I'm very hypersensitive to, overly sensitive to my body's, input and stuff. So
Yeah.
I think for someone who experiences that in more of a hyper state, okay, I'm always blown away when I see it in patients that clearly, like, no, they're hypo aware of this. They
Yeah.
don't have much sense. And even some of the descriptors of how they describe stuff, like you said, like, I don't know, I'm not
Yeah.
aware of this. Okay.
Yeah. Do we have any evidence that you're aware of that if someone has a really high functioning insular cortex right hemisphere, that these are the people who are more empathic, people who have like gut intuition, they feel the pain and of others? Is that a connection we can make?
Absolutely, you can make that connection. You can make that, the primary um, emotions of the right hemisphere are empathy and sympathy and disgust and actually this new term that's been showing up in the literature now called rejection sensitivity. Okay, that the right brain is and really from a standpoint of looking at this on a social context, what could be one of the worst things that could happen to us is that they're socially rejected
Rejected, yeah.
from society or their family for some reason. Okay, so so the idea that the right brain is more about these what they refer to as negative emotions. Okay, that and back to the world of development of especially in the autism community and throughout the spectrum. Many of those children and adults, they don't have empathy, they don't have sympathy, or
Yeah.
they don't experience disgust or shame. Okay,
Right.
so now the flip side of that, in the world of the creatives actually have a high right brain. So what you're describing is what we see in a lot of these amazing musicians or artists
Mhm.
or movie producers that tend to have these very gifted right hemispheric aspects, but it makes them more prone to having these very overdriving emotions that
Right.
really can cause them a lot of problems and cause social anxiety, can cause depressive disorders. Okay, so can cause eating disorders. Actually, Dr. Melillo and I did a podcast recently on that whole conversation of that topic. So
Yeah. 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 It's all fascinating stuff. All right. Let's merge into the vagal system. You were just talking about transcranial stimulation. So I know that there are many different methods to try to activate the vagus, right? There's transcranial, there's magnetic, there's transcervical, there's auricular, and probably the most common thing practiced in functional medicine are simple things like coffee enemas,
Yep.
with the idea that the polyphenols can drive sensory afferentation up through the vagal afferent system into the vagal nuclear system and then back out through the efferent. So out of all of those things, it sounds like you have a much broader perspective on this than I do. Of all those different options, like you mentioned the transcranial stuff, is that because that's the easiest thing for you to do and study, or is it because you've compared that to, say, the auricular approach and you found it to be more effective? Like, what's your sense of the different modalities available to drive the vagus? And that's presupposing that we understand that vagal output and control is one of the ways that we can connect brain and immune system and start to control that relationship.
Yeah. Well, we are playing with different vagal systems right now. We're actually playing with one of the units that Dr. Tracy has worked on with his team, and that would probably be more the cervical unit that we'd be using. But we all have also used different forms of auricular, and also using low level laser as a potential way to impact the vagus. So, on the transcranial side of things, we're doing that to maybe impact more specific neural networks. Okay. So if we want to address maybe that overactive direct pathway that we feel is playing a big role in those mesolimbic type of disorders, the mood disorders, okay, especially in the autism population, the OCD tendencies that we see with them. Okay, we're going to use that, but we may also come in behind it with vagal type of applications, and again, I think it really just comes down to the type of case that we're working with. If we're working with a child, we may try to do some passive types of modalities to the vagus. If we're working with adult, maybe we do some of the active types of way to activate the vagus, but then also do it with a passive modality. Okay. I think there's still a lot of work that needs to be done in those arenas to try to figure out, like, is there one or two go-to, companies that, like, we feel like we've got the frequencies nailed down. Okay. And I know, like I said, we feel very confident that, the work that's coming out of Tracy's lab in Long Island, they seem to be the really big pioneers in this work. So we're looking at that unit that they're using to see how we can. I know, like, for example, we have a study that's coming out of Rob's lab in the next month or two on heart rate variability that he's done, and being able to look at, again, addressing the brain asymmetry. So I know where our work is going next is that we're going to try to look at more of these vagal mechanisms into immune modulation, and also can we use that to make a change in brain asymmetry and in that functional imbalance. And then we're going to start trying to nail down what are some of the most stable, blood markers that we can look for. Because I think that I'd like to get your take on that in terms of, like, labs and how you feel about, the stability of actually measuring cytokines. And, because I think to me,
there's challenges there for sure.
There's challenges on that. Okay. And whether you're doing it, through flow cytometry or, and so, I think that's where we want to go with that, is trying to nail down, okay, what are some of the markers that can give us, we're going to get maybe the systemic relationship, but we may not get the local relationship that's happening.
And I think that's one of the biggest things. Like, there are many labs now that offer, serum cytokine levels, but, what you find in the serum is the sum total of all the different places and parts that are making cytokines. So that's kind of like a global average. But I think, especially now with this perspective that the immunoception, at least a component of that, is local tissue memory. It is quite possible that in local tissue, whether it's a joint or your thyroid or your pancreas, that local inflammatory environment can be completely different than what you're seeing in serum. Yeah. And so I'm not saying there's no utility in measuring serum cytokines or doing something like a lymphocyte map and looking at cell populations. I just don't know that you can extend it beyond this is a reflection of global status, which may or may not have anything to do with the particular system or tissue I'm interested in. And that's one of the big challenges.
Yeah, and I think the other challenge that comes into play is the nature of the naive T cell and how fast it could actually change and morph into. Because I think when we probably early learned it, we probably learned it in a very static way where, hey, it's TH1, TH2, TH17. And now we're beginning to understand that with these autocran loops that they can morph really fast and for one moment be pumping out maybe a Th2 system and then switch right into a Th9. So how do you account for that? So I think for me, I'm looking at it more based on global brain relationships and how can I modulate the autonomic nervous system and monitor the networks of the brain, and then try to say symptomatically, okay, hey, this patient has shifted from a Th2 dominance now to more of a Th9 because they're making copious mucus, and that's happening in their lung fields. And so, okay, now how do we maybe back down Th9, and what compounds are we beginning to know? Because I think we are getting better at understanding what compounds are impacting these cytokines. The question is, how do we measure these cytokines?
Well, and I think maybe another aspect that I've struggled with is that if you take any herbal compound and go to PubMed and try to figure out which cytokines it either increases or decreases, sometimes it's a combination of things. Yeah. And sometimes it's context specific. Like in one circumstance, compound X will do one thing in a particular cell type, but a different context will do the opposite. Or it's just it's never easy. Yeah, is maybe the takeaway.
And that's where I think. Go ahead.
No, please finish that, because I wanted to go back to the transcranial stuff.
Yeah, so and that's what I was going to go back to. So I think for me, merging the two disciplines is, I would probably say we try to be a little bit more brain centric and try to say, okay, how can we look at the networks and get the networks to be modulating better and synchronizing better, and then be able to then look down, peripherally, because you talk about, especially in some of these adult patients that we're looking at a lot of these pain syndromes, inflammatory systems. But one of the things that I know that Dr. Melillo and I have seen over the years of when we're teaching is that we're teaching predominantly to an adult population of practitioners or therapists that are taking our course. And when we start to delve into primitive reflexes, and we start delving into, how to examine primitive reflexes, and we pull a population of these practitioners onto the stage and we start checking, we're always blown away that probably 9 out of 10 adults have retained primitive reflexes. And one of the most common retained primitive reflexes we see is the Moreau reflex, that is part of the fight or flight reflex, or even the fear paralysis reflex that's not inhibited because the Moreau reflex never fully integrated. So looking back at, again, these patients, even in the PTSD world or the mood disorder world or the pain inflammatory mechanisms, if you're not checking for primitive reflexes and you're not looking at that role of what's happening at the brainstem level, I don't know how you work through that process for that patient.
Yeah. So as it relates to all the different modalities that you could use to either address the cortical aspects of this immunoception or vagal and peripheral tissue, would you say it's a fair thing that there are certain modalities like transcranial or maybe the photobiomodulation that would be more applicable to the brain side of things, whereas when you do some kind of a vagal stimulation, even though the vagus is part of the central nervous system in that respect, that's really more of a peripheral tissue, because you're trying to activate the vagus to harness the descending cholinergic parasympathetics to inhibit inflammation in the cells and the tissues. Do you think that that's a fair distinction to make?
Yeah, I do believe that's a fair distinction. And I think that that's why, we kind of layer it in relationship to that. We may try to go in and we do vagal aspects, especially if we're dealing with some type of gastrointestinal inflammatory mechanism, we'll use vagal aspects. But here's the thing that I think is often forgot about the vagus, is that the vagus is also anatomically related to a lot of those vestibular nuclei. Okay.
Mm,
And all of a sudden, back to the adult patient,
yeah,
and they have underlying vestibular dysfunction. Okay. Which really might be built on top of the fact that they actually have retained primitive
primitive
reflexes that have to
reflexes.
do with the vestibular system, like the asymmetrical tonic neck reflex, the symmetrical tonic reflex, or the tonic lavent reflex, and you haven't looked for that, you may
Yeah,
not get, because the immaturity in the brainstem itself, that you might be going in there and you might be trying to drive a vagal activation, but the overall system
right.
longitudinally is
Yeah,
very immature. Okay,
yeah,
so I think that that's a big thing that we gotta, again, I continue to press upon. I think in the functional medicine world, because you know, as you know, I'm out there, I'm lecturing, and I'm also part of different groups, and you know, one of the groups being a part of is the coaching's group, and so I get a lot of times I'll get some of these functional medicine practitioners like, hey man, will you mind taking a look at this case for me from a neurological perspective, because I
yeah,
think that might be a missing piece. That
yeah,
here I am, and sometimes it leads to self doubt to some of these practitioners that are out there that, you know, hey, they're sharp people. They're in these groups. They're going to postdoc programs. They're
yeah,
getting their staying on top of their continuing ed and everything, but they're getting beat up out there. And I'm going like,
yeah,
you might want to make sure you're making that relationship with a really qualified functional neurologist
yeah.
that can come in and do some co-management with you, because I just don't think in these broader cases of complexity that you cannot, you know, get to the quote unquote bottom of this without, you know, in the integration of both.
Yeah. And so, like, because there's a growing subset of functional medicine, even functional neurology practitioners that are opting to do predominantly or entirely virtual, like my practice is entirely virtual. And there are some things that I can do observationally from a
Mm-hmm.
neuro exam standpoint. I can even have somebody stand up and, you know, do some
Yep.
cerebellar fine motor control stuff. I can get a general sense of what's happening. But with respect to these primitive reflexes, is that something that must be done hands on, or is that something that you can have someone do a self evaluation and report back? Like, how would someone who has a virtual practice think about implementing that? Or is the only choice you have to be present and hands on, or find someone in your community like a chiropractic neurologist that can do this in
No, I
conjunction?
think, I mean, I've been working virtually, you know, even long before COVID,
Yeah,
and so I think you can teach it. You can usually teach it to the patient. Really can't do it on themselves. They need their spouse, or they need some other
yeah,
person to perform it. But you definitely can, you know, instruct people on how to do it. Okay, and you know, we keep it pretty simple, where we're looking for like 7 primary reflexes. Um, that we're going to check. We're going to check the palmar reflex. We're going to check the rooting reflex, the snout reflex, the Babinski reflex.
hmm,
Then we're going to go and look at the spinal galant reflex on the back, and then the Moreau and the vestibular reflexes that are there.
yeah,
So about 7 or 8 reflexes that, you know, once you create a system for it, can be taught in a few minutes, and for the most part, they're probably going to be able to observe that it's there.
yeah,
Okay. And then once
yeah,
it's there, you know, there are very specific remediations that can happen. But,
yeah,
you know, like I said, I really believe that this has to be part of the adult neurological exam in chronic patients.
right,
I rent space out of a practitioner's office, and you know, my colleague Craig Steingraber, and I know that's something that he started doing about several years ago. He worked that into his physical exam in his general musculoskeletal
yeah,
funk med type of practice, and he was blown away with like
yeah,
how many primitive reflexes that he was finding
yeah,
in just his general population. Okay. And
yeah.
then starting to try to do rehab on that.
And maybe a note of encouragement to people who are listening, who are getting a sense of like, I should probably learn more about the brain and the immune system. Like, you don't have to become a chiropractic neurologist and actually get your diplomate. you can learn some fundamentals and begin to implement them. In fact, when we were both going through the programs, we didn't wait till we became diplomates to do this in practice, right? You learn it in bits and pieces, you learn the fundamentals, you start doing the fundamentals, then you start to realize there's more to the fundamentals, and you learn more stuff, and you just keep adding to your toolkit, so to speak, over a period of time. So I would encourage people not to shy away. And maybe the answer is, to connect with you guys in your developmental courses that you teach. And we'll make sure that we put, whatever links you want me to put out for other practitioners that you think would be of interest and helpful to them. I'll put those in the episode description. So let's, I have a couple of more questions.
Sure.
But we should probably bring these 2 episodes. I would love to have you back to, like, maybe we could do a whole session on primitive reflexes and just kind of the fundamentals.
Yeah. Or, I think at one point it would be great. Maybe we tag team it with Dr. Melillo and we get him on this thing as well.
Yeah.
And,
we can get both you guys on and just, talk about the work that you guys have been doing and maybe get, some practical training. But, quite often, like, I'll go back to, like, when I teach the brain chemistry seminars, inevitably there's maybe 2 chiropractic neurologists that are in the room that understand the brain the way that you and I perhaps do. Everyone else is completely naive. Like, they have whatever basic training they had with their DC or DOM or MD degrees, but they really don't understand how the brain works. So we keep it very, very simple. And one of the things that I quite often encourage people to do, like when they're presented with these, like, immunoception type cases where the brain and the immune system are just not working together well, and maybe there's some aspect of this mesolimbic plasticity, maybe there's some vestibular issues. Like, I tend to present it in the case of, for example, with a mesolimbic plasticity case, that part of the brain that controls stress responses and inflammatory responses is just very good at being stressed and inflamed.
Correct.
And once you develop this negative or maladaptive plasticity, you can't undo that. Like, it's not like you can go in and snip the wires and stop the system from working. What you can do, though, is increase the adaptive or positive plasticity of other systems that are the natural braking mechanisms, right? And the vagus activation will be part of that. But I generally tell them, like, you want to activate the frontal lobe and the cerebellum. And that's very generic. I understand that. Yeah. And it's not patient specific. And then I will ask them, like, what's the one thing you can get people doing that uses their cerebellum and the frontal lobe? And usually there's crickets. And then my answer typically is exercise.
Yep.
And particularly exercise, things that you've not done before or haven't done for a long time, things that involve changes in position and balance. And I do remember one doc in one seminar, he, basically after this discussion shared that he had a long-standing history of anxiety and chronic pain and all this kind of stuff. And he and his wife took up ballroom dancing. And after 3 months of ballroom dancing with no other changes in his life, all of a sudden his anxiety was gone. And so, like, the whole class was like, holy crap, that is amazing. But that's how the system's designed. So right. At a very generic fundamental level, what is one thing that you would encourage practitioners to think about coaching and counseling their patients on that would be at least start moving their brains in the right direction to start getting control of interoception in general and maybe immunoception more specifically?
I mean, first thing is just muscle tone. I mean, I think that would be the biggest thing. I know even when in the child developmental arena, I mean, we're just, how many sit-ups can you do? How many push-ups can you do? Can you do some chin-ups?
Can you do those?
Okay, can you do those? Okay.
Can you do those?
Can you lie on your back and lift your hips off the ground and maintain a bridge for 60 seconds? Okay. I know we teach in the developmental course, there's normatives on that. There's normatives on can you hold a forearm plank? Can you hold, push-up plank? Okay. And so right off the bat, I think that's something that, and obviously we know that in the inflamed population, that may be a thing like, hey, okay, well, I know Dr. Karazian's been talking about for quite some time. Well, let's just get a sustained contraction of a muscle.
Yeah, even if it's isometric, right?
Isometric, right? Exactly. Something that, so in my patient population, and I work with quite a bit of the geriatric community as well, and I'm doing that, and they're always coming back and saying, wow, I can't believe just doing that simple exercise like that is making my brain function better. So to your point is, can we drive that cerebellum vestibular complex? Okay. Like what you're doing right now, just moving your head up and down and going in a yes pattern. Okay. Firing that vestibular pathway or firing in a horizontal pathway like that. Okay. Especially if we want to impact maybe some of those vagal centers that, so doing horizontal rotational movements. So again, just having patients just try to do some of these simple cerebellum vestibular pathways that then we know are going to have a consequence on those frontal lobe pathways that we will explore more in a later conversation. But those 5 primary loops that are going to come down and, like you said, have that descending inhibitory inhibition, especially on those mesolimbic pathways. And I think that's where, back to, not to pick on functional medicine so much, but I think that, we lose sight of that, right? We're not doing some of that in the workup with our patients and saying, okay, how do I load the brain? Okay. And our background is going to be that. We're going to try to say, hey, let's go activate you've been physically into fitness and doing everything you're doing. And I know that's something that has been a huge part of my life for the last 10 years through, various type of fitness programs. And I know my brain is working better than it's ever been, probably because I go, like you say, and introduce all these different dynamic aspects, whether it's TRX straps or kettlebell movements. And I'm literally now more than ever doing that with the younger generation of kids. I'm telling parents to, hey, get your child a little 5-pound kettlebell and let's start teaching them all these dynamic maneuvers. Because in the earlier days, we spend so much time focusing on static posture and okay, again, supine bridge stability and lying somebody on their stomach and seeing, can they hold out their extremities and extensors? And I saw changes in brain function. But then one day it just dawned on me, well, what if I start having them now do some more dynamic maneuvering? Okay. And we started doing that, and lo and behold, they started developing even more complex cognition and language and so on. So I think that's the biggest thing, is trying to get people to understand that movement is probably the most important thing they can do. Okay. And then from there, making it a little bit more specific for that particular patient population.
Yeah. Yeah. I've said a lot lately, like in social media stuff, that if I was forced to, like I would order diet and exercise. Like I would choose diet and exercise modification over nutritional supplements anytime as a clinician, right? Because you can't out supplement a bad diet. You can't out supplement a sedentary lifestyle. Yet, we have so many people, even healthcare consumers, who they don't want to change diet and lifestyle. They just want to know what supplement to take to fix XYZ. And sometimes that works out. That probably will come back and bite them in the end. But ultimately, it's, functional medicine is it's just about more than the supplementation.
Yeah. And I know, for me in the geriatric community, one of the things I've been having those patients do for many years now is go on, Amazon and buy, a real inexpensive whole body vibration platform that they can use and then teach them how to do, just again, some basic exercises that they can do.
Sure.
There's normatives on, can you do a sit to stand, test, and so, all that. And so I think that's the biggest thing, is you start out with, can I load the cerebellum? Can I teach people that there are basic norms? And I remember years ago, my patients were shocked when I showed them that, listen, we know that there are normatives on how many sit-ups you should be able to do when you're 60 years old or 70 years old. People are like, really? I'm like, no, there is. And so you start showing them those norms, and you just start trying to get them to work towards those things. And so, I think that to me is one of the best ways that, especially the right brain, because the right brain has so much to do with more of your visual spatial relationships. Again, this idea of where your body is in space and time. Your right brain has a lot more to do with your overall gross motor function, as opposed to the left brain being more about fine motor aspects. So that's the thing that I'm always trying to get all my patient population to do, is to get more movement in their life.
Yeah, especially the general stuff. I have a handful of cases right now that, the ones that really stand out to me are combination of Lyme and neuroautoimmunity. And, these are people, like most of our complex cases, that have failed with 7, 8, 10, 15 other practitioners. And, I'm the Obi-Wan Kenobi, the final hope. Yeah. And so in the last year or so, I developed what I call my Ground Zero program. And I'm not ready to share that with anyone, but it's just me playing around in my own little mad scientist laboratory of a practice. And, it focuses in on baseline, like assessing VO2 max capacity, doing VO2 max training at capacities that they can recover from and not exceed their metabolic tipping point, and then introducing global movement patterns that form the foundation of human movement. And what I've heard you just say, at least I think I did, is that when you look at gross movement patterns, things like squats or deadlifts or presses and pull-ups or rowing movements that use the shoulder girdle and the hip and the posterior chain complex, yes, you're firing your entire brain, but there's a more specific focus on right hemisphere activation, which then has tremendous benefit for interoception and immunoception.
Correct. Yep.
And this is why for years, people like you and I have said, not just movement is medicine, movement is, let's call it brain nutrition.
Absolutely.
Right? You feed your brain by moving your body, because you can't move your body without using your brain.
Yep.
Right?
Yeah, and the idea is always, the technical term for this in neuroscience is motor cognitive binding. Okay. That cognition is built on the complexity of the motor system. Okay. And this is, again, work that Dr. Melillo has extensively written on with Dr. Leisman for many years. They have multiple papers on this, and the textbooks alluded to this. But, and this is what we again see in the developmental world, okay, is that in these children with these various developmental disorders, and regardless of where they are in the spectrum of that, or even genetic disorders, okay, I work with a lot of genetic disorder children, and again, you see the simplicity of their motoricity, and hence why there's very limited capacity on the cognitive component of it, or even in the social, emotional development. Now, as you start maybe improving on some of those milestones that should have happened in the early development of under 3, because again, the primary hemisphere that develops is below 3 years old is the right hemisphere. Okay. And so when you look at, that, and you see that in these children where you go, wow, they have low muscle tone, they have vestibular issues, they now have ocular motor alignment problems. Okay. They maybe had retained primitive reflex, like the rooting reflex that never actually fully developed, and they couldn't latch on to the nipple. So now, okay, they don't get the benefit of the breast milk. What are we doing to the microbiome? I mean, all these things that are happening there. Okay. But even in the adult, you can look at it and say, okay, hey, I mean, I really believe that a lot of the primary problems in these chronic cases are probably mostly due to underlying problems in that right hemisphere. And now we start treating into it more, that we're going to have so much more success with these cases.
Yeah. And I think, this whole, the motor cognitive binding, like anybody who has a child, like, that they learn to pick their head up, roll over, sit, stand, and walk well before they can speak or, start to think with any type of rational, critical reasoning. And the motor system develops in that sense way before all the other higher capacities. We should probably call it quits just for the moment. And maybe, over the next day or two, we can talk about getting both you and Rob on. I would keep talking, but I want to respect your time. So let's leave it with this. What is your advice to someone who's in functional medicine who maybe doesn't have a robust understanding of the immune system or the neurology system, who's dealing with complicated cases where the standard protocols that you normally use aren't working? Just simplify it into a couple of minutes if you can. Like, what's your best advice for them to get started on how to see these cases and maybe fill in these holes of what they should do clinically?
Yeah, I mean, I think it just starts at, with your educational process, whether they can catch a course, through, the Karazian Institute or Cogent Immunology. And I don't think you have to delve into every one of those courses to become a master. I think you can segment it in and even, take some of the courses that, Dr. Melillo and I are currently teaching that, we've made it segmental. And so we try to, take a specific topic and narrow in on that particular topic. But I think that that's the biggest thing, is that if you're trying to get to some, or even some of the stuff that Jeff Bland's been doing recently with Aristo Rajani and others, that, gets you into that mindset of understanding immunology. I would highly recommend that patient get Abbas's book, Basic Immunology, as kind of like their base time textbook to begin to learn the terminology, because I think it's the terminology that really gets people caught up. That
the difficult thing with that is that terminology changes, every few years. Like terminology that was used, if you read an immunology or even a brain paper from 15 years ago, sometimes the terminology today is different, and you can easily get tripped up that way.
Yeah, and I think you bring up a great point that we talked about, like the T-cell polarization. If you're reading a paper that's 2010 or from 2000 to 2010, that's not how we look at T-cell polarization anymore. 2015 and beyond has changed the whole way we look at that. So exactly. I think that trying to, one, at least get a framework of the basic anatomy and some of the basic physiology. Read papers. I mean, I know you're reading papers, I'm reading papers. I think that you try to read a couple papers a week, and that'll help reinforce some things. And then, you try to find some of these webinars or, some of these courses that are online that you can take and delve into it. And like, I think the point that you made about going through Neurodiplomate was, we'd leave a weekend course and then you start applying it. And I'm sure, because I know I've heard the T's talk about this over the years, and I'm sure you have the same feelings, is that, how many people show up in a weekend seminar and then don't start applying it, okay? Because they feel like they got to learn it all before they can apply it. When I know when I was learning it, some of the basic blood chemistry from you just say, Scire, just go draw blood and then go look at a panel. Just go do it.
Ready, fire, aim.
Yeah, exactly. And not be scared to, like, hey, you don't have to know it all. I think you just have to have some basis of it to do it. And so I think there's enough good coursework that's being taught collectively that's out there. And if you find an instructor that seems to resonate with you and your learning style, just start, learning from those particular people and create a little bit of a network. And then I think you'll start picking up on this more. And the same thing with, like the primitive reflex work. I mean, that's something that, we can teach in a weekend to a group of practitioners and turn them into, like, okay, you're going to go out and be able to do this examination on patients and then have some treatment modalities for it. So, yeah.
Right. Perfect. Awesome. Dr. Peter Scire, thank you for educational and even inspirational topic and chat. I truly appreciate it.
Absolutely, my man. Thanks a lot, Steve. Appreciate it so much.